Good morning, student. Today we have lecture on the scalp. Competencies for the today's lecture are: describe the layers of the scalp, its blood supply, nerve supply, and the surgical importance of the scalp. Objectives for the today's lecture are: what are the different layers of the scalp, nerve supply, blood supply, and the lymphatic drainage of the scalp, applied anatomy of the scalp, especially what is the dangerous area of the scalp, what is the black eye, and emissary veins, which already we studied. Scalp. It is a soft tissue covering the cranial vault. The forehead is included in the scalp. So, the scalp is the soft tissue which covers the cranial vault, and forehead is included in the scalp. Its extent: anteriorly it extends from eyebrows or the supraorbital margin. Posteriorly, it extends up to the external occipital protuberance and superior nuchal lines. Laterally, it extends up to the superior temporal line. So, in this diagram, schematic diagram, anteriorly the scalp is extend up to the eyebrows or the supraorbital margins. Posteriorly, it extends up to the superior nuchal line and laterally up to the superior temporal lines. So, in this diagram, you can nicely appreciate these are the supraorbital margins, okay, on both the sides. Here is the superior nuchal line on the laterally and the inferior, sorry, not nuchal line, superior temporal line and the inferior temporal line. Both two lines are there, superior and the inferior temporal lines. And here is the zygomatic arch. This is the posterior view of the skull, which shows these two parietal bone, and these are the sutures, okay? And this is the occipital bone. Here you can appreciate the external occipital protuberance from where the superior nuchal line extends. These are the superior nuchal lines on the right and the left side. Below that, there are the inferior nuchal lines. So here is the external occipital protuberance and the superior nuchal lines. Subdivision of the skull. A line extending from the auricle to the vertex on each side divides the corresponding half of the scalp into anterior and the posterior quadrant. So the scalp is divided into anterior and the posterior quadrant by a line extending from the auricle to the vertex on each side. Okay. Now coming to the layers of the scalp. There are 5 layers of the scalp. The first one is the skin. Second one is the connective tissue or the subcutaneous tissue. Third one is aponeurosis, which is also known as the gala aponeurotica with the occipitofrontalis muscle, loose areolar tissue, and the pericranium. So, first layer is skin, second layer is connective tissue or the subcutaneous tissue. Third one is aponeurosis or the gala aponeurotica with the occipitofrontalis muscle, loose areolar tissue, and the pericranium. So these are the 5 layers of the scalp, and according to the spelling of the scalp, you can remember SCALP. Okay. So in this diagram, you can nicely appreciate the 5 layers of the scalp: skin and the connective tissue, then aponeurosis, that is the epicranial aponeurosis, then loose areolar tissue and the periosteum. Okay. First, we will see the skin. Skin of the scalp is thick and very hairy except forehead. Plenty of hair follicles, sebaceous glands, and the sweat glands are present in the skin of the scalp. So the scalp is the commonest site for the sebaceous cyst. So the skin of the scalp is thick and very hairy, and it contains abundant of hair follicles, sebaceous glands, and the sweat glands. And therefore, the sebaceous cysts are common in the scalp. Second layer is the connective tissue or the superficial fascia. It is characterized by the dense connective tissue. It contains the blood vessels, nerves of the scalp. Fibrous strands in the superficial fascia are fixed to the walls of the blood vessel. This factor prevents the retraction of the blood vessels when injured. Hence, the scalp wounds bleed profusely. So, the superficial fascia is characterized by the dense connective tissue. It contains the blood vessels and the nerves of the scalp. Fibrous strands in the superficial fascia are fixed to the walls of the blood vessels, and this factor prevents the retraction of the blood vessels when injured. Hence, the scalp wound bleed profusely. So, this is the answer why the scalp wounds bleed profusely. Bleeding of the scalp is controlled by application of a direct pressure of the digit or by placing the sutures. Subcutaneous hemorrhage are not extensive since fascia is dense. Inflammation causes the little swelling, but they are much painful. Third layer is the musculoaponeurotic layer, which consists of two parts, epicranial aponeurosis or the gala aponeurotica. Here you can see. And the muscular part composed of frontal and occipital bellies of the occipitofrontalis muscle. So the occipitofrontalis muscle has anteriorly frontal bellies and posteriorly occipital bellies, and in between there is a epicranial aponeurosis. So third layer is musculoaponeurotic layer, consists of two parts, epicranial aponeurosis and the muscular part composed of frontal bellies and the occipital bellies. Gala aponeurotica, which covers the vault like a helmet. Anteriorly, it merges with the superficial muscles between the two frontal bellies. Posteriorly, it is attached to the occiput and the superior nuchal line. Laterally, partially attached to the superior temporal line and fuses with the temporal fascia. Here is the temporal fascia and the superior temporal line. So here is the gala aponeurotica. Muscular part. Frontal bellies arise from the skin and subcutaneous tissue over eyebrows and the root of the nose. Posteriorly attached to the gala aponeurotica in front of the coronal suture. So here you can see the frontal bellies which are arising from the skin and the subcutaneous tissue over the eyebrows and the root of the nose. It is supplied by the temporal branch of the facial nerve. Action is raise the eyebrows and produce the horizontal wrinkling on the forehead. That is the action of the frontalis muscle. Okay. So here you can nicely appreciate the frontal bellies. Okay, and here in this diagram you can see the occipital bellies. Occipital belly takes origin from the highest nuchal line and it is inserted into the gala aponeurotica. It is supplied by the posterior auricular branch of the facial nerve. Alternate contraction of the occipital and the frontal bellies moves the scalp forward and backward. First three layers of the scalp are fused with each other and moves as a single unit, hence known as the surgical layers of the scalp. The three layers of the scalp, first three layers of the scalp, they are fused with each other and they move as a single unit. Hence, they are known as a surgical layer of the scalp. Aponeurosis. Gala aponeurotica. It is present between the occipital and the frontal bellies. If it is cut transversely, it produces the wounds of the scalp. Okay. If this gala aponeurotica is cut transversely, it will produce the gaping of the wound. The fourth layer is the loose areolar tissue or the subaponeurotic layer. It forms a potential space filled with the loose areolar tissue below the aponeurotic layer. It extends anteriorly into eyelids because of the frontalis has no bony attachment. Posteriorly to the superior nuchal line, on each side to the superior temporal line. So this space is closed on all sides except anteriorly where it extends into the upper eyelid. So the loose areolar tissue of the subaponeurotic layer forms a potential space with the loose areolar tissue below the aponeurotic layer. Anteriorly, it extends into the eyelids because of the frontalis muscle has no bony attachment. And because of that, this space is closed on all the sides except anteriorly where it extends into the upper eyelid. Posteriorly to the superior nuchal line, on each side to the superior temporal lines. So the loose areolar tissue space is closed on all the sides except anteriorly where it extends into the upper eyelid. Bleeding causes generalized swelling of the scalp. This layer is called as a dangerous layer of the scalp because emissary veins open here and carry any infection inside the brain. Bleeding leads to black eye. Caput succedaneum in the newborn baby. So that is the clinical importance of the loose areolar tissue space. This space is called as a dangerous layer of the scalp because emissary veins open in it, and we know that if there is any infection from these emissary veins which may be carried into the brain. So these are the 5 layers of the scalp, okay, from skin, connective tissue, aponeurotic layer, loose areolar tissue, pericranium, okay. And here is the emissary vein here. So they can carry the infection. Dangerous area of the scalp. The fourth layer of the scalp, that is the loose areolar tissue area, is known as the dangerous area of the scalp. Infection in the subaponeurotic space with the pus collection readily spread to the intracranial sinuses through the emissary vein, and therefore it is known as the dangerous area of the scalp. Black eye. If there is blow on the skull, collection of the blood in the subaponeurotic space produces the generalized swelling affecting the whole dome of the skull. Blood slowly gravitates into the eyelids because the frontalis has no bony attachment anteriorly, and therefore it will produce the black eye. If there is blow on the skull and after that there is a collection of blood in the subaponeurotic space, produce the generalized swelling affecting the whole dome of the skull, and blood will slowly gravitate into the eyelid because of the frontalis has no bony attachment, and therefore this condition is known as the black eye. Pericranium. It is the periosteum of the skull. It forms a loose covering for bones except at the sutures. Injury deep to it takes the shape of the bone, that is known as the Kefal hematoma. Scalping injury should be replaced and stitched because of the healing is better because of the more blood supply. Kefal hematoma is the collection of the blood below pericranial fracture of the bones of the vault. This occurs, Kefal hematoma occurs when there is a fracture of the pericranium and the blood will collect in this layer. Kefal hydrocele, accumulation of the CSF below the pericranium due to the tear of the dura mater and arachnoid matter, which will lead to Kefal hydrocele. Such a swelling are restricted to the bones of the vault and they will take the shape of the related bone. So these are the 2 important conditions, Kefal hematoma and the Kefal hydrocele. Kefal hydroceles occur because of the accumulation of the cerebrospinal fluid below the pericranium due to the tear of the dura mater and the arachnoid matter. And such swelling are restricted to the bones and bones of the vault, and they will take the shape of the related bones. So here is the picture of caput succedia and the picture of the cephal hematoma. Again caput succedia. Here will occur the cephal hematoma. Here is the subglial hematoma, epidural hematoma. These are the various sites where you can get the caput succedia, cephal hematoma, subglial hematoma, and the epidural hematoma. Okay. Coming to the nerve supply of the skull. Anterior to the ear, it is supplied by the one motor and the four sensory nerve. Posterior to the ear, it is supplied by one motor and the four sensory nerve. Anterior to the ear, scalp is supplied by the supratrochlear, supraorbital, zygomaticotemporal, and the auriculotemporal nerves. And these are the sensory nerves, and they are from the trigeminal nerve. And the fifth one is the temporal nerve, which is the motor nerve, which is the branch of the facial nerve, and it supplies the frontal belly of the epicranius muscle. So anterior to the ear, it is supplied by the four sensory nerves, and the scalp is supplied by the four sensory nerves, and these sensory nerves are supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal nerves, and these are the branches from the various divisions of the trigeminal nerve. So the supratrochlear is the branch of the ophthalmic, supraorbital is also the branch from the ophthalmic division of the trigeminal nerve. Zygomaticotemporal is the branch from the maxillary division of the trigeminal nerve, and the auriculotemporal nerve is the branch from the mandibular division of the trigeminal nerve. And the fifth one is the temporal, that is the motor nerve, that is the branch from the facial nerve. So here you can see supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal. Okay. Nerves behind the auricle. Posterior branch of the great auricular nerve, it is sensory nerve, lesser occipital nerve, greater occipital nerve, and the third occipital nerve. All these four nerves are the sensory nerve, and the posterior auricular branch of the facial nerve is the motor, which supplies the occipital bellies of the epicranius muscle. Okay. So the posterior branch of the greater auricular nerve comes from the cervical plexus, lesser occipital from the cervical plexus, greater occipital nerve from the dorsal ramus of the second cervical spinal nerve, third occipital nerve from the dorsal ramus of the third cervical spinal nerve. Okay, so these are the nerves behind the auricle. Posterior branch of the greater auricular nerve, lesser occipital nerve, greater occipital nerve, third occipital nerve, and the posterior auricular branch of the facial nerve. Coming to the arterial supply of the skull, 5 sets of arteries supply the skull on each side, 3 in front of the auricle and 2 behind the auricle. Arteries in front of the auricle are supratrochlear, supraorbital, both are the branches from the ophthalmic artery, superficial temporal artery, posterior auricular artery, and the occipital artery. These are the branches from the external carotid artery. So here are the arteries supplying the scalp are supratrochlear and the supraorbital arteries. These are the branches from the ophthalmic artery, and the ophthalmic artery is the branch of the internal carotid artery. And posteriorly, there are superficial temporal artery, posterior auricular artery, and occipital artery. These are the branches from the external carotid artery. So there is free anastomosis between the internal carotid artery and the external carotid artery. Venous drainage. The veins of the scalp correspond to the arteries. Supratrochlear and the supraorbital veins join at the medial angle of the eye to form the angular vein. Superficial temporal vein enters the parotid gland and joins with the maxillary vein, and it will form the retromandibular vein. Posterior auricular vein unites with the posterior division of the retromandibular vein. Occipital vein usually terminates in the suboccipital venous plexus. So the venous drainage of the scalp through the supratrochlear, supraorbital veins, superficial temporal vein, posterior auricular vein, and the occipital vein. Diploic veins. What are the diploic veins? These are the large, thin-walled, wall-less veins that channels in the diploe between the inner and the outer layers of the cortical bone in the skull. When you will see the study the skull, that time you can see the two layers, inner and the outer layers of the cortical bone, and that time you can realize how these diploic veins are located there. They are lined with a single layer of endothelium supported by the elastic tissue. They develop fully by the age of 2 years and drain this area into the dural venous sinuses. 4 major types on each side of the head are the frontal, anterior, temporal, posterior temporal, and the occipital diploic veins. So there are 4 major types of diploic veins on each side of the head are frontal diploic vein, anterior temporal diploic vein, posterior temporal diploic vein, and the occipital diploic veins. So the diploic veins are the large, thin-walled, wall-less veins that channels in the diploe between the inner and the outer layers of the cortical bones of the skull, and they are lined by a single layer of endothelium. They develop fully by the age of 2 years and drain this area into the dural venous sinuses. And there are 4 major types of diploic veins. On each side of the head are frontal, anterior temporal, posterior temporal, and the occipital diploic veins. Lymphatic drainage of the scalp. The anterior part of the scalp, except the region below the center of the forehead, drains into the pre-auricular or the superficial parotid group of lymph nodes. The posterior part of the scalp drains into the posterior auricular or the mastoid group and into the occipital group of lymph nodes. So the lymphatic drainage is divided into anterior part and the posterior part of the scalp. In the anterior part of the scalp, drains into the pre-auricular or the superficial parotid group of lymph nodes except the region below the center of the forehead. The posterior part of the scalp drains into the posterior auricular or the mastoid group and into the occipital lymph nodes. Coming to the clinical anatomy of the scalp. Scalp is the commonest site for the sebaceous cyst because of plenty of the sebaceous glands are present in the scalp. Blood supply of the scalp is rich, therefore bleeding is profuse when there are wounds of the scalp. No supply of the scalp is rich, therefore the infections of the scalp are more painful. Scalp laceration. Wounds of the scalp bleed profusely because of the abundance of arterial anastomosis. Arteries do not retract when lacerated because they are held open by the dense connective tissue in layer. Local pressure is the only way to stop the bleeding. So the wounds of the scalp, they bleed profusely, and reasons are: 1, because of the abundant arterial anastomosis is there. Okay. Then arteries do not retract when they lacerated because they are held open by the dense connective tissue layer. And to stop the bleeding, local pressure is the only way to stop the scalp bleeding. Remember this. Deep scalp wounds needs to be sutured because they gape widely when the epicranial aponeurosis is divided. This is because of the tension of the aponeurosis produced by the tone of the occipitofrontalis muscle. So the deep scalp wound must be sutured, otherwise they will gape because of the epicranial aponeurosis. Caput succedia, temporary swelling in the newborn. Edematous condition of the portion of the scalp due to the interference of the venous return while passage through the birth canal. This is the caput succedia. Cephal hematoma. Collection of blood below the pericranium is known as the cephal hematoma. Localized swelling which assumes the shape of the related bones. It may be when it is traumatic, then cephal hydrocele may occur. Infections in dangerous area of the scalp enters the cranium through the emissary veins, causing the thrombosis of the venous sinuses, osteomyelitis or the osteomyelitis of the cranial bones. In infants, veins of the scalp easily sink deep to the skin, hence they are used for the IV infusion. So this is all about the scalp. You may get full question on the scalp or the short notes on like this. Enumerate the arteries supplying the scalp, now supply of the scalp, or clinical anatomy of the scalp. Thank you. This is all about the scalp.